Any questions to start with? All right. Lifting and moving patients. Something that you will do every shift. So, biggest thing is protecting yourself when it comes to lifting. Obviously, nobody wants a back injury. For anyone in here that's ever had a back injury, they suck.
Yeah.
They're horrible. They lay you up for a week, 2 weeks, or longer, depending on depending on how bad you break it or bust it up. They can be long. Workman's comp also don't like it because they got to pay you for a long stretch of time to rehab. So we want to practice good body mechanics. So we want to make sure we keep our back straight. We're bending at our knees. You guys have probably all heard this in one way or another between your jobs throughout your careers. But always consider this stuff when you're lifting patients. They say the object, but let's be faith, like the patient. Let's not be mean, calling them an object. But look at them. Judge their weight. It's one thing you'll probably become good at is looking at somebody and going, no, they're about 180 pounds. So start thinking about that. Start looking at things, trying to judge their weight before you do that. And think about, do you need any extra help? Is this person 550 pounds? So do you need more than 2 people to lift that? Do you need fire department to help? Do you need another truck to help? Think about those things, always going through the back of your head. Especially if you're going to a residence that you might know, that somebody that's large that lives there. Start your resources early, knowing that you're going to need them. Know your limitations. Don't be afraid to admit that I can't lift that weight. It's nothing to be ashamed of. Just know your limitations, and communication with your partner is huge. Don't try to lift and then your partner lifts. You got to be on the same team. Count it out. 1, 2, 3 lift, or 3, 2, 1 lift, or ready, set, lift. However you want to do it. You always want one person to be in charge. Don't both of you count at the same time. That way there's no confusion and you don't end up counting differently. Position your feet properly. So we're going to be about a shoulder width apart when you're lifting. You're going to lift with your legs, so you're going to bend at the legs, keeping that back straight. And don't twist or turn. So don't try to lift this way and turn this way if you can help it. Whatever you like. This is how those back injuries happen, or those compressions when you twist. The twisting adds so much more stress to your back, your muscles, your bones, tendons, ligaments. That's one of the times where you're going to hurt yourself the most. Even though it's the repetitive nature of the business that tends to hurt your back the most. I threw my back out on a simple lift, on just lifting a person properly, and popped my entire lower back. Felt really great for about 2 weeks. So keep your weight as close as possible to your body. Keep that good low center of gravity. Use a stair chair when you're carrying up and down stairs. We'll go over that. We'll look at one here in a little bit. They do help tremendously on stairs. If you have the people, it's a great idea to have that spotter on the downward side of things. Walking backwards downstairs takes some practice. So here's your power lift and power grip. So when you're lifting, you're not lifting like this when you're lifting the stretchers. You always want palms up, and you're gonna lift again with those legs back straight, and you're gonna lift like you're curling, like you're doing bicep curls kind of thing. I don't know what I hit right there, but again, when reaching, keep your back in a locked position. This comes into play when we're moving patients from bed to bed. So if you're leaning across, you want to keep that back straight out, locked in that position. You can use your knees. You'd be surprised at actually how much lifting you can do with your knees when you're reaching across the bed, and you can lift over. Again, avoid that twisting while you're reaching. Don't reach too far in front to the point where you're at a very awkward angle. Again, we want to try to keep that center of gravity is to our core as much as possible, as low as possible. And don't be stretching out, and don't be waiting for other people. So if you're doing this for too long, waiting for someone else to do it, and they're taking forever to get things set up before, just let go and stand up. Don't stay in this position for long. You're going to lock yourself out, or you're going to just overstrain yourself. You can push rather than pull whenever possible. It's not always possible in this business, but try to always do things that's going to use the least amount of. That's easiest. Pushing is always easier than pulling. Keep your back locked in. Keep a line of pull through the center of your body, and keep your weight close to your body, and keep that center of gravity. If you're down below your waist, you really want to kind of try to do it from a kneeling position if you can. We'll do a lot of things when we're moving patients, like for cardiac arrests, if they're on the floor already. Sometimes you'll be getting down on your knees and sliding them along the floor to get them into a better position to do CPR. People, unfortunately, don't typically collapse in the middle of the floor. They tend to collapse between the bed and the wall, or the toilet and the wall, or the toilet and the shower. They don't ever collapse in a convenient spot.
Stairs.
So when you're moving someone like that, where it's like down on the ground, don't be bending over to move them if you can help it. Get down on your knees and, like, as a team, move them. And move them just a little bit at a time. You don't have to move them. I know it's a stressful situation, but slow things down in those cases. Move them carefully, because if you hurt yourself, you're not going to do them any good. All right. Let's talk about emergency, urgent, and non-urgent moves. So emergency moves are obviously for kind of like hazardous scenes. There's life-threatening injuries that require immediate repositioning, or requires immediate extrication from a vehicle. And so something like that would be like a car that's on fire that can't wait, smashing a window. Usually, obviously, extrication can take time. We want to pop the door, try to move them. But in a situation where a car might be on fire, it might be bash the window, grab them, and pull them out. That would be kind of an idea of an emergency move, where there's life-threatening conditions and they require repositioning. So you would do something like that, where you'd smash a window and just pull them out, not worrying about injuries that they might have sustained. You're just trying to get them out of that life-threatening situation. Closed drag's another version of this. So if you have to drag someone out of a building, if you're a firefighter, you might use this. If it's a bad situation, you might just grab them by the clothes and start dragging. Notice how he's on his knees doing this. He's not doing it from a hunched over position on his feet. Incline drag, always head first. You don't want to bounce someone's head down the stairs. Doesn't look good, but notice how he's using his knee there. He's using that thigh as he's stepping down. So he's helping using his legs to take that weight. And you lower him down slowly from stair to stair, trying to take as much weight and using your whole body as possible, not just your arms and your back. Firefighters drag. I've personally never really seen this one, but apparently tying their hands together, putting it up over your neck, and then drag them as you're crawling along. I've personally never seen this one or practiced this one, but never even seen. I don't remember even being taught that in fire one.
No, must be a city fair thing.
Must be. But obviously it's in the book, so it's obviously an approved way to move someone. So this I don't see as relevant to our job. It's more of a relevance to firefighting.
Yeah, I've seen this in a different class, but it was in reference to if you're going interior and your partner goes down and it's not safe to stand up to drag them out.
Gotcha.
You
Okay.
need to stay low and crawl out. That was a safe way to get two out without exerting yourself to the point where you're creating more hazards.
Makes sense.
But I don't think even in that class they said it was a practical thing to practice.
Yeah, it doesn't seem like it. Seems more or less you grab them by the back of the tank and just start dragging from your knees a little bit at a time as best you can.
Apparently that's supposed to be less stressful and you exert yourself less, so you're taking less breaths, so you have longer. But that was the only time I've seen it presented.
I know. I'll tell my dad about this, so the next time they do an air pack drill in Johnson, I'll have them try it, and I'll have them get back to us to ask what way was easier, this or dragging someone out of their smokehouse.
What's
I don't really care.
Exactly.
I'll volunteer to be the patient. They can drag me.
Oh, there you go.
So another one, a blanket drag. Yeah, again, I think it's not really much of an EMS application. I don't really see us a reason where we'd be doing an emergency blanket drag on a patient. Again, I think it's just more of a directed towards firefighting, which is kind of a weird crossover with EMS and the way fire service works and everything. But I don't. The only time I could see this is if you happen to get yourself into some sort of situation where you have to remain low, some sort of hazardous materials, things that you get mixed up in. But other on like a day-to-day operations, I don't see this being something that we use a lot of.
It's almost like they want to put the idea in their heads so it stays there, like in the back, just in case. You know?
Yeah, and you never know where these ideas might come up,
Yeah.
and you're going to develop your own ideas too that just come to you in the middle of a call. Like the time we used a 2.5-inch hose to lift the patient off the ground. Because nothing worked. Sheets, blankets, everything ripped because this lady was so big. So the fire department brought up 2.5-inch hose. And we literally just shimmied it under her butt and basically threw it up the lengths around our shoulders and everything, and basically like lifted her with hose just high enough to get her on the stretcher, and then used the hydraulics of the stretcher to stand her up. So you'll be surprised at what you can come up with.
Poor hose.
Yeah. So that was the day I found out Leatherman wrappers cut through 2.5 like it's butter.
Good to know.
But so you'd be surprised at what you come up with in the heat of the moment for ideas to do this. So other emergency moves is like a 1 rescuer assist, and you have your 2 rescuer assist. So these are for, I don't know, I'd say most of the time we use these for like drunk people that tend to stumble around. But you may use them for they may be necessary for stroke patients also. Sometimes when they're weak on one side, we may just have to support them to get them to the stretcher or the stair chair. You'd be surprised at how many places you go into that you can't get anything like that into a bedroom. It happens. So sometimes your choice is like they tell you, don't walk a chest pain patient. That'll be one of the things that come up when we do cardiovascular diseases. Minimize the stress that you put on them. However, there's going to be situations where you're not going to have a choice. They're going to have to get up and they're going to have to walk 10 feet just due to circumstances of the environment.
That happened literally yesterday. I was at a barbecue right next door, and they showed up, and she just walked out onto the stretcher.
Yeah.
I was like, okay.
So sometimes it happens. Sometimes patients insist on it, just dignity-wise. But so we want to make sure we support them, get their arms over your shoulders, over your neck. Make sure you're giving them a good support system with your opposite hand, and basically you're taking their weight and you're walking with them, walking for them or walking with them as they take steps. Urgent moves are required treatment can be performed only if the patient is moved. So I would say like these urgent moves would be more of our cardiac arrest patients. I know it sounds weird that they wouldn't be considered in the emergent section of things, but cardiac arrests, where we're talking about people that fall between the bed and the wall. Well, you can't provide treatment until you move them. So it's an urgent move, so you can provide treatment to them. It's not necessarily an emergency move where there's some sort of life-threatening environmental issue that requires them to be moved. Usually involves moving patients to a backboard. Not all the time. Sometimes we just use a sheet. Sometimes we use the carpet that they're on. Just drag the carpet with you. So there's different ways you can do that. Backboards do work good if you have the room to use them. Non-urgent moves, going to be here. Oh, and there's not really anything that says what specifically an urgent move is. It's going to be defined by what you do in the field, what you come up with. So sometimes that may be if it's a cardiac arrest patient and you can't get to somebody, get anything under them. That may be just as much as you grab that foot, I grab this foot, and you drag them out. That could be an urgent move. So it's basically just whatever you're going to come up with in the field that dictates moving these patients to a place where treatment can be provided. So non-urgent moves, these are, patients aren't involved in life threats. These are the, they're sitting in a recliner. You can assess them, you can treat them, you can start treatment on them while they're sitting in their living room in their recliner. And then to move them, they can easily just stand up of their own accord and sit on the stretcher or walk all the way out to the ambulance. These are kind of your non-urgent moves. But obviously also always take precautions so you don't aggravate any sort of existing conditions. So you don't want to if they're having difficulty breathing, you don't want them to walk 50 feet to the ambulance. So don't do anything that might exacerbate that COPD or asthma attack that they're having. But it's okay to get them up and walk them a few feet to a stair chair or stretcher if need be, and they can do it on their own if necessary. All right, we have a number of different carrying devices. Some of them are arrayed out behind you there. We have power stretchers, we have manual stretchers, we have bariatric stretchers, which are typically rated for people over 800 pounds. Normal stretchers are typically rated out to 600 or 700 pounds. Then after anything above that, you have to get into the bariatric stretchers, which are wider, a wider stretcher.
The closest one that has that is UVM, right?
UVM or St. Mike's? I can't remember which one has it. You're talking UVM like Rescue or HealthNet?
I don't know. I just know UVM has one of them because they had the winch and
Well, they got one on
all
their
that
critical
stuff.
care
Right?
unit.
Yeah, it's the HealthNet you're thinking of.
Yeah,
HealthNet. So HealthNet is UVM Medical Center's personal critical care teams.
Okay. Yep.
Then there's UVM Rescue. So the college has its own rescue team apart from the college.
Oh.
So, but yes, the critical care team does have a bariatric stretcher. They have a winch in the truck, and they have it's like a ramp that goes down, and the winch pulls the stretcher right up, so nobody has to lift that. So, they have all the money in the world though at UVM, so they get all the fun toys like that. But they are great. I have seen them before on one patient that I had in Maine. They work. We had a bariatric stretcher for our service up there. They are good. They have extra handles on the side, so you can get 6 people. So you can do 4 people on the corner and then 2 people on the side, and it has like a bar that pulls out and locks in that you can lift. So you can get like 6 people on these stretchers to lift them. But I don't think anyone in Franklin County has one though. This is a powered stretcher. You can see the battery pack right here. See all the hydraulics underneath there. They're great. The big thing with stretchers is when you're moving, especially across uneven ground, it's very important that you keep that center of gravity low. The higher you go, the more tipsy they get, especially when in this position, which would be called the loading position. So when a stretcher is all the way up, we'll show you more when we go out to the bay. We'll pull one out. The stretcher actually sits at a slight angle for loading position. So that makes it kind of tipsy, whereas when you lower it down, it's more flat. So that center of gravity stays more center and lower. So anytime you're on rocky ground, it's best to stay low. Have multiple people on the sides if you can. This is Furno's version of a powered stretcher. It's a little different than Stryker's, which I think everybody in Franklin County uses Stryker's. There's a few services, I think, around the state that use the Furno device, which is a little different. I saw one at the conference. They're really no different than Stryker's. They run off battery power. Their just controls are slightly different. So here's a bariatric stretcher being pulled up using the winch. The tracks and everything come with all this stuff. So they are nice. Like I said, they are wider. So I think I want to say they're like 24 inches across or something, so they're about 2 feet wide versus I think only 16 or 18 inches from a normal stretcher, so bigger people tend to fit on them better. Stair chairs are awesome. You never hear me complain about them. They're great when you can't maneuver a stretcher in. So they're called stair chairs because obviously their initial development was for bringing patients up and down stairs, but they work great as just a wheelchair. You got a tight corner you can't get the stretcher in, you can get the stair chair in. So works good for that stuff too. So then we have our spine boards, which we don't have a short board because they don't really get used in EMS practice anymore. So they're not around. They're really not around on trucks anymore. Then we have our long boards, which are like the orange board in the back there. So our long spine boards. So usually we use these for basically just moving patients nowadays. It says from vehicles with neck or spine injury is suspected. We'll talk about more of that when we get into trauma. Not really immobilizing patients anymore. There's a picture of the stair chair. There's also one right there. Again, we'll play with these things once we break from it. Other types of stretchers, we have portable stretchers, scoop stretchers, basket stretchers, flexible stretchers, and vacuum mattresses. Here's a scoop stretcher. The metal one in the back there is the scoop stretcher. So this is basically a board that breaks into half. So you can see the white sections on each end. So there's a little button you pop and it pops apart. So it breaks into 2 spots. So when you have someone that's got like a hip injury, you can break it apart and go in and literally scoop them up. so you don't have to roll them, so you're not aggravating like a hip injury or a leg injury or a spine injury. You literally can just scoop them up. Question on?
What's the weight on them?
They can take quite a bit. I've put some 300-400 pound people on them before, so they can take quite a bit. But the straps, you also have to look at the straps too, and the ability to wrap them around. Sometimes you might have to use like old-fashioned 9-foot straps, and you might have to use spider straps, which are a different type of strap for larger people sometimes. So, basket stretcher or Stokes basket will be another name you might hear it by. Typically carried by fire departments and other like rescue personnel like that. Typically not carried straight on ambulances. It's typically something a fire department will bring.
Typically not transported that way.
Yeah, typically you're not transported on a scoop. Usually once you get to the ambulance, you're taken out of the scoop and moved to a stretcher, either with a longboard or...
Those look like any movie I've ever seen ever that has like a paramedic, like a helicopter rescue type thing.
Yep, they would be used for lifting patients onto a helicopter too. They're great for wildland rescues too, if you got to go up on the long trail. They actually have some of these that they have like a built-in off-road tire mount that goes underneath it.
I have one.
You guys have one? Yeah, Johnson has one too. They work great. Yeah, because you just get a few people on each side and it just balances it and it rolls right across the ground. So it's so much easier than carrying. Work smarter, not harder.
It's bumpier for the patient though.
It is, but
Compared to what they have.
that's what pain medication's for.
Exactly.
So this is a flexible stretcher. Personally, never seen one. But I guess they're out there. It looks like it folds up in the center, probably. So it probably folds in half, kind of thing.
Yeah, we got one at funeral home.
Do you?
Yeah.
Look at canvas.
Like a
Yeah.
top, yeah. We used it once.
So a vacuum mattress. Vacuum mattresses are actually kind of a really cool thing. So this is like a full body one, They make them actually vacuum splints, and they also make. So anyone in ski patrol might be familiar with vacuum splints. They're fantastic for splints. They're also very great for full body immobilization. They're great for hip fractures with little old ladies. So what it is it's a soft thing, a soft pad. You lay the,
chair.
huh?
It's like a beanbag.
Yeah, like a beanbag chair, and what you do is you put them on it, you secure them in, and then you take this little pump here, and you suck the air right out of it. So it basically takes a beanbag chair and makes it rigid. It actually works really well for hip fractures on little old ladies, or any sort of like multi-trauma where you might have multiple injuries that need splinting. So in this case, and so that's nice, and then it's hard. It doesn't bend, it doesn't flex very much. So you can actually lift them up on it and move them to a stretcher with minimal, without having to use a backboard or a scoop stretcher. So they work really well.
Very comfortable.
Yes, and they're comfortable. I've had multiple patients say how comfortable they are. I actually had a 90-year-old broke her hip. This is back, I think, when I was an EMT. And we put the lady on one of these things and wrapped her right up like a cocoon, sucked it right dry, and her pain went away just from the splinting. So they work really well.
Wow.
I don't know, is anyone carrying them? Anyone actually have them? Yeah, we don't either. We have some of the...
Trying to get them.
Yeah, I'd love to have a set on every truck here. They're fantastic. So
You can use them for heli rescue too.
Yeah.
It's a spine board. It's everything you need for splints.
yeah, and that's the other thing that's great over the long backboards is, as it says here, like it conforms to the body. So there's always, whenever you put someone on a board, there's always this gap right here that actually ends up hurting a patient because of that lumbar support. Well, this actually like conforms to the body, so you actually get lumbar support here for them. So that helps make it more comfortable. So, I mean, how do you choose the appropriate patient carrying device? I mean,
It kind of depends.
it's all dependent on the situation.
Yeah.
So patient with suspected spinal injury. We've got manual stabilization. It's where we're holding someone's head. We're applying a cervical collar. We want to restrict the movement of the neck and the spine. Immobilizing head, neck, and spine before move. This is where we're going to get controversial with what we're going to teach you versus what you're actually going to do. We don't immobilize patients anymore. Immobilization of trauma patients has been taken and punted out. It's actually been discovered to be more harm than good to patients. Now it's actually better to let patients splint themselves. So C-collars get applied and then patients get put in what we call spinal motion restriction, which is basically them just laying supine on the stretcher. Patients are going to do what hurts them, right? I mean, anyone in here has probably had that. You don't do something that's going to hurt yourself, unless you're some sort of sadist, I guess. But but they found that patients are more comfortable and actually do better self-splinting. And backboarding and immobilizing patients has done more harm over the course of time than not. So that's a new thing. So, but again, we'll cover more deeply in trauma when we start actually doing this. Extremity lift. This is where I wish we could. There you go. Extremity carry. Forgot they actually put pictures in here. Never done that one before, personally. Usually it's from the side. One takes an arm, one takes a leg, and each one of you go from the side, not front and back like this. But I guess it depends on movement, where you're moving to, how much room you have to move. If you have to go, the benefit to this, if you have to carry through a door, you don't have to worry about who's going first and who's going second and twisting and whatnot. You can just walk straight through a door. So I'll have to try this one next time I get a chance.
Not only that, but his whole upper body is kind of like supported by obviously the front guy, instead of like, you know, like I'm just imagining somebody trying to hold each arm, and that just sounds more uncomfortable than what that is.
Yeah, no, you're right. And the other thing too that benefits this is if someone's unconscious when you're doing this and the head flops back, your chest is going to prevent them from going and like fully extending or fully extending their neck. So in this way, it's a little bit better. My advice to you: if the patient's vomiting, be this guy. Important information.
Until he flops his head back.
Yeah, but your chest is protecting that from happening, so it's still going to go forward. And if you're good, if his head flops back and then forward, you might actually be able to arc it into the back of her head. You have to think about these things. When patients are vomiting, you always put yourself where you're not going to get vomited on.
In other words, don't be Joe's partner.
Yes, exactly. Hey, it took me 11 years as a medic to get vomited on, and it happened in the middle of an ER as the patient goes to vomit this way, and the nurse says, no, not that way, and turns right towards me and just soaked the entire way down my side. 11 years. 11 years I made it without getting puked on.
I'm guessing you had a real good relationship with that nurse after that.
Oh, I gave her a lot of crap for that after that. That's another reason too why I'm so lenient and so giving with my Zofran or any antiemetic. Oh, you're nauseous here. Don't like vomiting. It's one thing that I just listening to someone yak is just not a pleasant sound to me. Anyway, but yeah. So direct ground lift, this is where we're going to lift them from a patient like this. We're going to lift them with no sheet. You want to get yourself to the lowest possible position that allows you to stand up, so you can see they're kind of that position of one knee on the ground, the other one kind of bent at a 90 degree. Trying to keep your back as straight, but I don't know. I don't ever see anyone being able to keep their back straight. Neither one of them have a straight back right now. Know it. My advice would be do your best never to use a lift like this. Always try to use an aid.
So she looks like she's 100 pounds soaking wet. You know,
Right. So here, then you're going to bring her up to your knee. Then you're going to help use your legs to support the weight while you reposition your hand grips, whatever you need to do. And then on the next signal, you're going to bring them up to the stretcher. So this is actually from a ground to like a kneeling position. They're not coming straight to a standing position.
Why would you use that one instead of like one at each end and just kind of?
That's what I would do. Is someone grab underneath the knees or thigh area so you support that hip, while another person gets underneath the shoulders. So then it's a little easier to support the head, and then you can lift them kind of from a seated position, because you're gonna lift them kind of at the hip and bend them up. You come up underneath the shoulders and you can lock your hands in. Whereas this, if the patient suddenly squirms and they do this, like you could very easily lose your grip and dump them over. Whereas if you're lifting up from someone from behind, you can come in under their shoulders, and you can lock your wrist in, lock your hands in underneath there, or you can grab their wrists themselves. Yeah.
Other than, like, in this photo, obviously there's not room. Why wouldn't you have one person on either side so there's not the inclination to just dump the patient off your arms when they start squirming? Because I don't think it's an if. I genuinely.
It's
like,
a when.
It's a when.
Oh yeah, it's 100%.
So, in that case, why wouldn't you do your best to just scooch them out before the lift to make a better lift, and then position one person on either side? Is that more in practice than in teaching, or?
No, I think it's a valuable thing. I think it's just they're trying to show you different approved lifting techniques in this, and this happens to be one of those lifting techniques. Personally, I wouldn't ever do this. I would do something like you're talking about, Felicia, where position the stretcher maybe down at the feet, like in the doorway, and then lift from both sides and move them this way onto it, or have someone push the stretcher underneath after you lift them straight up. If there's because this looks like an office, so I imagine there'd be an LNA or a nurse or somebody that could just scoot that under you as you lift them on a sheet. So personally, I don't like this lift. That's why I say kind of know it, but there's definitely better ways to do this. All right, so draw sheet method. So this is kind of your hospital bed to stretcher, or stretcher to hospital bed when you're delivering patients. Typically not done with just two people. Typically there might be 2 or 3 of you, usually one on each, usually one here, then one person at the feet. You're going to do like a 3-point lift and move. You can do it this way. I have found that half the time you end up pulling the sheet out from under the patient more than actually pulling them. So, but as you can see, so they outstretched, backs locked, count it out 1, 2, 3, and you basically pull to you. But I don't know. I've never done it. I've always done it from one from each side. With this, in this case.
Wouldn't this way they wouldn't really be lifting them? They'd be more like
you're more dragging.
And
yeah.
That might not feel very good.
No. No, to me, I always try to at least lift a little bit, so you at least bring them off the stretcher, because that way you're not dragging them across that rubber of the hospital beds. But that is one of the ways. Again, I would usually do it one from each side. So, but this is another way that can be done. So, recovery position. I think we talked a little bit about this during medical terminology. So this is the promise I haven't had anything to drink today. This is the recovery position or recumbent position. She's currently in left lateral recumbent. Different reasons why we might do left versus right. Pregnancy, we'll usually do left. Sometimes it's just a position of whatever position the patient wants. So if they're more comfortable on the right side, let them lay on the right side. Pregnant ladies, we typically do left side. Positioning for shock is important. So place patients believed to be in shock in a supine position. It used to be, if you've probably seen, they still do it in TV shows. They're in shock, lift the legs, lower the head. They might tip them down. They still do it in some of the hospitals around here too. That's no longer the thing. It's been shown not to work. It doesn't do any good for the patient. So they just lay them flat. Don't raise their legs. Don't lower the head. Just lay them flat.
What about a suspected head injury? You want to keep the head slightly up, or?
Head injury, I would keep the head slightly up just to help the whole idea of gravity. It'll help keep the brain from. You don't want to go too high because you don't want them to drain you don't want gravity to pull everything out of the head. Yep. But keeping them, 30 degrees or less would be good. That way, some gravity, so fluid doesn't build up too much in a head. So, transfer hospital bed, hospital stretcher. This is the modified draw sheet method. So this is kind of what we were talking about, using 2 people per side to move the patient from one to the other. This is the way it should be done. I think this should be called the draw sheet method, and the other way should be the modified draw sheet method. Because this is more realistic, this is safer for everybody, because it's 4 people taking the weight of the patient instead of 2. So this is the safest way to move a patient from stretcher to stretcher. Obviously, if they need help, sometimes when you move patients over, they might need a boost up. We don't always necessarily line up 1-to-1. So a patient may go up and they may need to be boosted up in bed. So obviously making sure that the patient's comfortable in the hospital bed, centered, they're not going to fall off before you leave them. Any questions on lifting?
This one wasn't on there in direct carry, when you're picking them up. Can you show this one?
Okay.
Do you use that?
Yeah. That's the one I told you to kind of keep in mind, but
It's different, and they're going from a bed from a waist high, and then transporting them into a stretcher.
Oh.
Which looks easy because they're already at your waist. So you
Yeah.
have to-
So it's the same thing as this. It's
Yeah.
just they're already at your waist level
Yeah.
instead of kneeling down to the ground to get them. So the biggest thing to take away with this chapter is just remember your body mechanics. Keep your back straight as much as possible. Don't twist when you're lifting. Try to use straight lines. Lift with your knees, not with your back. You really want to take care of your back. It's really your lifeline in this business. Without your back, if your back gets thrown out, you can't work. Trust me, as someone that has a bad back, like I take care of my back multiple times. Like I get a massage every month. I also go see a chiropractor. So if anybody is going to be planning on this a career, highly suggest starting to take care of your back now so it lasts longer. It was a hard lesson for me to learn. It took a back injury to learn this lesson, so I'm passing it on to you guys before you get that back injury that might end your career.
Was it on the job?
Huh?
Was it on the
Yes. Yeah. Yeah, I've only had out of work for 2 weeks. Light duty. Sucked. I had to sit in the office and be the manager's bitch, for lack of a better term, for 2 weeks. So I was very eager to get back to the truck at that time. But it was miserable. For about a week and a half, I couldn't get out of bed until I basically popped a flex roll. Once I had muscle relaxants, then I could actually stand up. I'd literally have to crawl out of bed to get to the medication. So it's not fun. So take care of your back, especially if you're planning on anything in the medical field. So, any other questions on lifting? Great. Let's take 5. And what we'll do is when you guys come back, we'll do the vital signs and monitoring devices. That should take probably about another half hour, 45 minutes to go through that chapter. And then it'll be 13, yeah.
3:38.
Then what we'll do is Courtney hopefully will be back by then. We'll break you guys up and we'll do some vital sign stuff in here, and we'll do some lifting and moving and stuff out in the bay. We'll actually get the stretchers out. We'll let you guys play around with the scoop stretchers and stair chair and stuff and practice with that. And we'll show you some other kind of tricks of the trade. So, one device actually we'll do it after. Never mind. Take a break.
I just go with the flow, man.
Let's get on with this.
I go with the flow.
Jump into the next section here, and vital signs and monitoring devices. Vital signs, it's kind of the bread and butter of what EMS does. Being able to take a good set of vitals, that's what we want. Vital signs are making where certain treatments may be viable, where other treatments might not be. Typically, we're basing this on pulse rate and blood pressure. So, when it comes to vital signs, if there's one skill set you can take out of this and become really good at, it's taking a good set of vitals. This goes for any level, from EMT to paramedic. Vital signs are what you want to be good at. So, gathering them. There's our major sets of vital signs out there. We have our blood pressure, our pulse, respirations, pulse oximetry, temperature, and even GCS is starting to be, or the Glasgow Coma Scale. They're starting to be is considered a vital sign now. We'll talk more about GCS with trauma, is where it mostly comes into play. But can come into play with medical patients also. Pretty much every patient you assess, whether it's a sign-off, a transport, an intercept, you should have minimum of one set of vitals. Obviously, if you have any sort of transport time from like Richford or Enosburg, you should have multiple sets of vital signs. Obviously, we have machines that make this much easier nowadays with monitors, but there's nothing as good as like your first blood pressure. There's nothing as good as a manual blood pressure for your very first blood pressure. That way you know if the monitor's malfunctioning or not. Because trust me, they do. If they get outside of maintenance range, sometimes the sensors in them aren't great. So sometimes blood pressures and that kind of stuff are thrown off. So having that first set that's manually taken by your own ears, by your own feel, that's the best.
Is there a variance with those?
With what?
With those machines as far as sensor-wise for blood pressure, for example?
There can be. Like I said, if they
100% accurate?
I mean, they're 99.9% accurate. I'm just saying, like any machine, when they get outside of a maintenance range, if they don't get their like yearly maintenance that they're done, sensors can go bad, and then they can throw readings off. So that's all I'm saying.
Electrical, like not an EMP, but something that can throw it off.
Sure. I mean, weather. I mean, this is your pulse ox cable for the monitor.
Yeah.
I mean, see how it gets kind of folded up in here?
Yeah.
Kind of gets stuffed in here, so
Wires.
wires can become loose. They can fray inside in the covering here. So they can sometimes work, sometimes not. They can throw your readings off just because of the way the electrical current works. So so that's why I say like becoming good at a manual set of vital signs. If you're good at that, you'll never have an excuse not to have a set of vital signs. Don't ever lie about vital signs. If you're ever first responding and somebody asks you what the blood pressure is and you're having a hard time hearing it or can't hear it, don't ever make one up. I had somebody do that to me, and I could have killed that patient by what they told me. So don't ever lie. Always admit, hey, I can't hear it. Why don't you take a listen? Nothing wrong with that. We're taking these during primary assessments. We're also taking them during secondary assessments. Sometimes we're taking them if there's immediate life threat. Sometimes we're taking them every 2 minutes. Sometimes we're taking them every 15. It's all dependent on kind of the patient's condition. Alright, so let's talk about what makes up the vital signs. So, pulse, respirations, skin color, temperature, condition, pulse capillary refill in infants and children. That's going to be skin color, temperature, and condition in children and infants. This is going to be kind of where we tell if a kid is sick or not sick. We're not going to be looking necessarily mostly at pulses and respiration. And blood pressure in infants is it's there, it's a reading you can get, but it's not really a reading that's going to affect treatment. Telling a kid, how many parents are in the room? Okay, when your kids were infants, was it pretty obvious to tell when they were sick, like just looking at them?
Yeah.
Yeah, same.
And as a parent, even no matter how old your kid is, you can just tell if they're not feeling well.
Yeah, so that's kind of the same thing with skin color, temperature, condition. When you walk into a kid that's not sick because mom called because they have 104, you're gonna look at that kid and go, that kid's sick, because they're just gonna look pale. They're gonna look their cap refill, which for anyone that doesn't know, Victor, I'm gonna borrow you here. Sure. Basically, take a finger and you pinch it until it's kind of right, and it should fill back up within like 2 seconds, less than 2 seconds. That's your goal for anybody, from infant all the way up to adults. Less than 2 seconds, that finger should refill with blood. Anything delayed means that there's a perfusion problem. Pupils and blood pressure are other outward vital signs. They say oxygen saturation is not a vital sign, but it's always considered and counted inside your vital signs. So like when you run reports and when you're writing them out either by hand, like the vital signs section will have a place for oxygen saturation. So even though it's not an official vital sign, it's still considered one. So our baseline, when you hear baseline set of vitals, It's your first set of vitals that you get. That is the baseline of the patient as you're dealing with them. Your repeat vital signs, this is where you're going to start gaining your information as to how their vital signs are doing. We call them trends. Typically, you need 3 sets of vitals to trend that information. So, if someone has a blood pressure of 124 over 76, then you get only one extra set of vitals that's 118 over 66. Okay, you can't determine a trend at that point because they're too close together. Both those blood pressures are perfectly normal, perfectly within normal ranges. So you can't really trend those. You get a third one. Now suddenly the blood pressure is 108 over 54. Now you can say there's a trend. Patient's blood pressure is dropping because it's trending downward. Or trending downward that way. So you need to have at least 3 sets of vital signs to kind of trend a direction of increasing or decreasing. Yeah, let's just go on. I forgot my thought on that one. All right, so pulse, palpable. Obviously, our palpable pressure is the heart beating, which is obviously what our blood rushing through our arteries are. So there's multiple different places we can find pulses. Okay, most common one, I think everyone's probably familiar, is your radial pulse, which is right here. Can everyone find their own pulse right here? It's usually right here next to your wrist bone. If you just kind of come in, you should just light pressure, you should be able to feel it. You might have to hunt around. Some people are slightly different with the anatomy as to where the artery is. You should be able to feel your pulse. They teach 2 fingers. You can use 3 fingers. I use 3 fingers a lot of times on the elderly, just because sometimes they're a little trickier to find with the way the skin might be a lot looser, or it might actually be a little bit more hidden to find it. So that 3rd finger just provides a little bit more surface area to try to feel it.
Might be that. No, found it.
Everybody find it? So that's your radial pulse, obviously either side. There's your carotid pulse, which is typically what we reach for on unresponsive patients. So you want to go in from kind of your trachea. It's going to be between your trachea and your jugular vein that's right here. So if you push it in kind of next to your trachea, you should be able to feel it. Everybody find it?
Yep.
That's easy. Okay. We always try to feel. Don't ever reach across somebody. Sorry, Victor, you're just sitting right here. So don't when someone's lying on the ground, we don't typically reach across from them. We always try to feel from the same side.
Okay. Gotcha.
Is there a reason for that? Yeah.
I don't know the
So if they
reasoning.
wake up, they don't.
I mean, like somebody reaching
Yeah.
across in your face,
Yeah,
you know?
It's more or less if they wake up suddenly on you, they don't have someone looking like they're trying to strangle you. So it's just, try to stay to the same side. Obviously, if you can't feel it here, but you want to try to check the other side to see if you can feel it better on that side, you can, or have someone do it. So those are typically the adult places. Typically the common places we're going to do is radial pulse, carotid pulse. Children, infants especially, we check the brachial pulse. And you actually can find this on yourself. Your brachial pulse is going to be, if you find your bicep in here, you should be able to kind of push in. It can be a little tricky to find on an adult, but you can find it. I've found mine before. There it is. So it's up kind of towards your armpit a little bit more.
Yeah, it's like right under your bicep up towards the top.
Yeah. So the brachial is where we typically will do young children and adults. Derek, are you guys going to be at Russell Road? Okay, so you did send them on that transfer? Okay.
Yeah.
Courtney's going to be around, so she'll help you with the stuff.
Okay, cool.
So brachials, typically, that's the common place we're going to reach for on infants, just because their hands and wrists are so small, we might not be able to feel a radial pulse very well, so the brachial is much easier to find on an infant. The other one, I'm not going to actually physically show this to you because that would probably be sexual harassment, is going to be your femoral pulse, which you're going to find, which can be very tricky to find, but it's typically, you're going to basically go right in here at the hip area, and you got to push in quite hard to feel it. I would suggest If you want to learn how to do this, you can do it on yourself. I would do this at home. Don't practice. But it can be, it's typically right here, kind of where the groin begins. If you push in real kind of hard, you should feel it in there. This one's common. We use this one with like CPR. If you're doing effective CPR, you should be able to create a femoral pulse. So that's another place that we check. Typically, this is typically done with, like I said, unresponsive patients, CPR patients. This is where we're checking. The other last two spots are on your foot. So you should be able to find it on the top of your foot here. You'll feel your two big bones here. And you should be able to feel your pulse kind of right in here. This one can be a little tricky to find. Usually if you're dealing with someone, say someone fractured their leg, and you find their pulse. So it's common practice and common courtesy, I guess, for like the doctors and nurses. Take a little pen or take a marker and like, oh, there's the pulse, and just put a little X on the foot. That way they'll know that, oh, pulse is right there. They can just reach in there and see that they have a pulse. The other place is you can also feel a pulse on the back side of your heel. That heel bone where your Achilles heel is, sometimes you can reach in there and you can feel a pulse. Not everybody you should be able to do this with, but some people you can. Every one of them kind of has a bit of a blood pressure kind of associated with it. It's not 100% accurate, but it can sometimes give you just a ballpark. So in order to have a carotid pulse, your blood pressure has to be at least 60, systolic. So this is a top number. So you have to have at least a systolic of 60 to have a carotid pulse. 70 for your femoral and 80 for your radial. Like I said, these are not 100%. They're just kind of a ballpark that if someone has a carotid and a radial, but not, or carotid and a femoral but not a radial, you could make an assumption that the blood pressure should be in the 70s. Again, not 100% accurate. Always try to get an actual blood pressure to do that. So what we're looking for is we're looking for rate and quality. How fast is it going and the quality? Is it strong? Is it weak? Is it irregular? Is it regular? Is it irregularly irregular? What I mean by that is it just like all over. Sometimes you'll have a patient it'll be, we call regularly irregular, so you'll feel the pulse and it'll go boom, 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 boom. It'll have that regular beat, but it'll suddenly be irregular for a short time. Irregularly irregular means it's boom, 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 boom. It's totally irregular. There's no kind of rhyme or reason to the pattern. Obviously, rate. Best way to do that: time 15 seconds, count the beats in 15 seconds, times it by 4. That'll give you your minute rate. Or you can do 30 seconds by multiply by 2, whatever you feel like doing for math. Eventually you should be able to get to the point of feeling someone's pulse, and within 5 to 10 seconds know that, yep, hey, their pulse is in the 80s. Or, hey, that's really, really fast. So you'll eventually get to that point the more and more you feel it. Anything above 100 is tachycardia, so fast heart. Bradycardia is anything below 60 beats per minute. This is an adult patient we're talking about, okay? So anything above 100 is tachycardia, anything below 60 is bradycardia. Kids often, like infants, typically run 140 beats a minute. They're always tachycardic. And it slowly comes down as they get older. And once they hit right about their teen years, they kind of get to that normal adult flow of 60 to 100 beats a minute.
That's why they have so much energy.
Yeah. So anything above 150 beats a minute is a serious finding. Once you start getting above 150 beats a minute, you probably would definitely want to start seeking advanced life support help on this. Once you start getting into arrhythmias above that, it can be a lot of problems for the patient. So 150 is anything that's above 150 starts becoming serious. Even 120 can be considered serious once they start getting above that with things like atrial fibrillation or patients that are septic, that is like really sick, have systemic infections. These can be kind of serious findings, and anything less than 50 beats per minute is a serious finding. Some people live in the 50s, especially people that are in really good shape, people that bike and run a lot. 50 beats a minute is like really nothing. There's even like marathon runners typically live in the 30s. So if you ever get that finding and they're perfectly acting normal, ask them if they're like some sort of like one of these marathon runners or these extreme athletes, because they probably live in that range. So
if you have a patient that's like consumed a lot of caffeine or something and they're 130, 140, is that concerning, or because you kind of know the reason that it's more pharma related than medical related?
I mean, if they consume that much caffeine to set their heart rate that high, I would consider that a serious finding. They've definitely not that in this job sometimes it's normal, but ODing on caffeine can be bad. So
amphetamines shoot that up that high?
Amphetamines can definitely get you tachycardic. PCP, bath salts. I don't know if you guys have heard of bath salts. They're a nasty piece of synthetic amphetamines that tend to.
Is that the drug that like makes you eat people or something?
Yeah.
Yeah. It's been there's been some cases of people eating others out of Florida. There's been cases where people just go. We've all heard the stories of people like on PCP where they can lift cars and they're like superhuman strength. Well, bath salts can also do that also. They're quite a nasty little thing. But yeah, so amphetamines, cocaine can also shoot your heart rate up. Anything that's kind of that, anything that's going to be that kind of stimulant can definitely shoot your heart rate up. And vice versa, anything that's a depressant can shoot your heart rate down nice and low. All right, we talked about regular and irregular rhythms on your pulse quality. Yeah, so pressure, force, is it strong? Is it thready? Thready is kind of what we use for that weak, thin pulse. It feels like it's that pulse of, ooh, that's really weak. I'm having a hard time feeling it. That would be that would be what we consider a thready pulse. Pulses should be strong. You should be able to lightly touch somebody's wrist and feel that nice boom, boom, boom of the pulse. It should not be hard to find. We went through the radial, brachial. Here's kind of like where we're looking on a child with a brachial. Carotid we went over. All right, respirations. Respirations is kind of what we want to know when we're dealing with patients that are having difficulty breathing or shortness of breath. We're looking for quality of the rise and fall of the chest. We're looking for how fast they're breathing. So we're watching their chest up and down. Again, it's kind of like taking a pulse, count 15 seconds or 30 seconds, whatever you prefer. Count how many times they breathe in and out, multiply it by 2. Your normal rate for an adult will be 12 to 20 times a minute. So one trick is while you're taking someone's pulse, check their breathing too. So this is where we're kind of multitasking. You got to keep track of 2 different counts in your head. I'm not saying you have to, I'm just saying it's an option for you out there. So we want to know how many times they take a breath in a minute. We want to know if it's normal, if it's slow, or if it's rapid. Our normal rate is 12 to 20, as I said. Infants will breathe faster. They can breathe up to like 30 to 40 times a minute. And as they age, it slowly drops down. Like toddler, 5-6-year-olds typically will be in that 20 to 30 range, and then as they get into that teenage years, we start to see the normal range of 12 to 20. Age, sex, size, and physical conditioning. This will all influence breathing rates. People that are skin and bones may have a slower breathing rate at a baseline. They may be at 12 times a minute for their baseline. Whereas somebody that's not in such physical condition, they may be breathing 18 to 22 times on a normal basis. Someone that has COPD, their baseline may be 22 to 24 times a minute. If they're fast or slow, sometimes we have to give them oxygen. Helps kind of do 2 things where we get a little bit of psychological first aid that they're getting help, the oxygen's coming in, and sometimes the oxygen will actually, they're getting enough oxygen in where the breathing rate will start to lower down just because they're feeling better, they're actually getting the oxygen they need. So we kind of put them in 4 categories: normal, shallow, labored, noisy. So normal, obviously it's like the way we're breathing right now. In and out without any sort of interruption or need to feel like we need to stop or take a deep breath. Shallow, these are patients that would be breathing like, you can have slow and shallow, you can have fast and shallow. So typically you'll see patients breathing like, so like if you're running, you might see shallow breathing. Labored will be patients that might be having, you might see shallow and labored together. You'll see accessory muscle use. You'll see the jugular veins right through here. You'll see them flare out, become distended. They'll be kind of sticking out. You'll see accessory muscle use. So you'll see the chest muscles kind of flaring in and out. You'll see them use them. You'll also see maybe the belly might be used to help with the diaphragm. These are all ideas that you're looking for. And noisy. So some patients, like when you walk in, someone's having an asthma attack, you may be able to audibly hear them wheezing without a stethoscope or without anything. Like from across the room, from me and Dominic, you might be able to hear him wheezing if it's a bad enough attack. So those are kind of noisy things you're looking for. You're also listening for like gurgling. If they might be full of fluid, so you might see gurgling or hear it. So things like that. That's what we mean by noisy breathing. If you observe irregular respirations in an unconscious patient, count it, report it, document it. Obviously, count your respirations, multiply by 2 after 30 seconds, or 4 if you're doing 15 seconds. And you're going to note your rate, quality, and rhythm of respiration. Any questions so far? All right. Skin. So we're looking at color, temperature, condition of the skin. Skin can tell us a lot about circulation, about how well we're perfusing, which is getting nutrients to the body, getting blood, getting oxygen around the system. So, best places. Nail bed. These are for adults. So, nail beds, inside of the cheek, and inside your lower eyelids. So, right in here, right in the corner of the eye here. You can look. You can see patients that are pale. This will be a very pale looking corner of the eye. Nail beds, you can see, you'll be able to do the whole cap refill thing. So you're, like I said, you pinch it and see how fast it changes back to pink. Someone that has compromised perfusion will have a slower than 2-second refill. Infants, we're looking at palms and soles of the feet. And then patients with dark skin, we look at the lips and nail beds. And the eyes can also tell us a lot too. Abnormal skin colors, so pale, cyanotic, which is like a blue-gray, you're looking for that blue-gray color, flushed, which is a deep red, and then jaundice is yellow. Jaundice you typically see with liver failure patients. Flushed patients can be a number of different things. Jaundice you typically only see with liver and bile duct issues.
Can be long term.
Huh?
Can be a long term.
Yeah, it's a long-term finding. If someone's jaundice, that means they've been in liver failure for a little while. It can get better. If the liver failure gets treated appropriately and properly, like jaundice can go away.
But you wouldn't see that in someone with an injured liver.
Probably not acutely, no. Typically, it's something that usually comes on with time.
Isn't the cyanotic lack of oxygen?
Yes. Yep, the blue-gray is typically a finding where we see in shortness of breath or difficulty breathing patients that obviously they turn blue because there's no oxygen getting to that particular area.
You can also see jaundice in children too, correct? Like infants, possibly.
Yeah, typically it's usually for the same reason. Usually it's for some sort of liver issue that's going on.
Yeah, isn't it when they're newborn too? They can be until you put them under the, I don't remember what it's called.
Yes, yeah, sometimes they can get the UV, they have that UV defect where they need that UV light I think so, if I remember correctly. So yeah, there is that one too. I think it's a pretty rare condition though, for someone to be born to. Did you have a question, Dominic?
Oh, no.
Okay. I just thought I saw your hand come up, that's all. So, temperature. Patient's back of the hand. We're looking for that kind of warm, hot, cool, cold, clammy, diaphoretic kind of feelings. Diaphoresis is just extreme sweating. See that in patients having heart attacks. Older people will typically have cold or cool extremities just at baseline. But what do you think that might affect getting
Their circulation.
affects their circulation? So we'll talk about it here in a minute. But pulse oxes with cold fingers can sometimes give you misreadings. Children under 6, we want to do the cap refill. You can do it on the hand or the foot with them. I guess you could do it on an adult too. Might be a little weird to, here, let me see your toe. But something you could do if you needed to. Normals less than 2 seconds, abnormals greater than 2 seconds. There's really only 2 findings to that. Pupils, black center of the eye, pupil will dilate with dim environment. Bright environment, your pupil will constrict up. We can test what we're looking for. We're looking for the size, equality, and reactivity. So when we look at someone's eyes, a lot of you guys probably have this. Have a little flashlight. You don't have to use these ones. You can use a regular flashlight too. But on the side, they all have the pupil sizes, and that's measured in millimeters. So usually the best way to I have found to test someone for this is shut the lights off in the back of the truck, or have them close their eyes and tell them I keep your eyes closed. I'm gonna open one lid at a time, and you open the lid and you shine the light in a little bit, come slowly across their eye, and you basically are looking for how fast that reacts. It should react pretty quickly. The pupil should react quickly. It should constrict right now with light. And then when you do the other side, you're looking for equal reactivity, and you're looking for it to constrict like the other one did. If it's slower than the other one, we would call that sluggish. Note baseline, people become big in head injuries, stroke patients, things like that. Anything to do with the brain. So cover one eye, shine the light into the other eye, or repeat with the other eye. So you can see constricted, dilated, and then unequal pupils. Here's a picture of someone with a dilated and a normal pupil.
So that's natural in some people, isn't it?
Yes, it is. It actually is. It is natural in some people. Some people do have just a dilated eye, or they have issues with one pupil, or some. But yeah, it is. Most people that do have this though will know they have this, and they will tell you. So then it kind of becomes a moot finding, something you want to pass along, so the doc doesn't come in and go, "Oh my God!" Yeah. Yeah, he has a head injury. Look at his pupil. Doc, he has that normally. Oh, why don't you say something? So definitely pass that on if they tell you that. I've seen it a couple of times. It's kind of interesting. It's kind of weird. Then again, I have a lazy eye, and it's kind of weird looking at me. So blood pressure. So blood pressure is the force of blood that pushes against the walls of our blood vessels. Our systolic blood pressure. So everybody's familiar with the way we write it. We get 120 over 80. So systolic blood pressure is the top. So systolic blood pressure is when the heart contracts. That's the pressure that's exerted against the vessels of the blood vessel walls. When the heart relaxes, this is called diastole, or the diastolic pressure. It's the resting pressure, the constant pressure that's always against the blood vessels. Normal pressure for systolic should be 120. Shouldn't be any higher than that. This is where it's going to get kind of funny. Normal blood pressure is 120 over 80. That is the book answer. Nobody in here is normal. Nobody has perfect blood pressure at 120 over 80. Some people live in the 130s over 90s. Now they have hypertension in this case. Anything over 120 is considered hypertension. But we don't really start worrying about it until we start seeing above 140. Diastolic, some people live in the 90s, some live in the 80s. Other people live at like 100 over 50. It's going to be all dependent on the person's physiology. Remember earlier I said that marathon runners typically live at the 30s on their pulse rates? Well, they may also be living at a blood pressure of 90 over 40 or 100 over 50. So that's their normal baseline. So when we say normal pressure is 120 over 80, that's the book answer. It's the test answer. In reality, nobody has a perfect blood pressure. Everybody's blood pressure is always changing. From minute to minute, second to second, our blood pressure changes. It's all dependent on what we do. Exert yourself, it's going to go up. Rest, sit down and rest for a while, it's going to drop. Change can indicate something very significant. If you're dealing with a trauma patient and blood pressure suddenly drops, say it goes to 80 over 60, what do you think might be going on with the patient?
They're crashing.
They're crashing, but they're going into shock because they're probably bleeding out internally or bleeding from somewhere that you might have, maybe you missed the bleed or maybe that tourniquet came loose. So you got to double check things like that. So this is why we want to be doing multiple blood pressures. Oh yeah, one of my favorite words in medicine. So blood pressure is measured with a sphygmomanometer. I love that word. It's just the fancy term for a blood pressure cuff. But it's a cool word to say, sphygmomanometer. And you're going to use a stethoscope. Your cuff should cover about 2/3 of the upper arm, elbow to shoulder. So you want to do it. There's different size cuffs. I only grabbed regular cuffs, but this is kind of your regular looking blood pressure cuff. They make child sizes, infant sizes, large adult sizes. They make a thigh cuff. So one that you can actually take a blood pressure around the thigh. Typically those are used with a machine. But you can take a blood pressure, you can put the blood pressure cuff on the forearm. And instead of listening here, you listen at the wrist. Same goes with the leg. You can actually wrap a thigh cuff around it, and instead of, you listen behind the knee.
Is that not going to change the reading you get a little bit based on where you're reading it?
It'll change it a little bit, but not enough to make a huge difference.
Okay.
So wrap the cuff around the upper arm. You're going to place the lower range of the cuff about 1 inch above the crease in the elbow. And then you want to try and place, you'll see it on the cuffs. Nobody's great with this. It sometimes can be a pain in the butt. But you'll see it actually helps you out. You're kind of idiot proof, but everybody screws this up. See where it says this side against the limb? Yeah, you'd be surprised at how many people do it the opposite way and put this side against the limb. But it happens to everybody, so don't feel embarrassed when it happens to you. So this side goes against, and then, so this little mark here, where it says artery, so you want to kind of line that up with the artery that comes down through your arm. So about center of the elbow. It's kind of where you want to line up. You want to help me?
Yeah, I was wondering if you were gonna. I was just gonna let you struggle.
I'll just have you wrap it around here. Perfect. But yeah, so you want to do your best to kind of line that up, because that's kind of where that bladder is.
It's not.
No. Let's see how bad my blood pressure is tonight, because I didn't take my medication today, so it's probably kind of high right now.
Way to go,
So that's kind of where your blood pressure cuff wants. Your stethoscope is going to go right, typically about the center. You can kind of offset it a little bit, kind of medially to it, so maybe right in here. Sometimes you might have to take it a couple times to find a really good spot. But usually right in here if you put your stethoscope. And one thing I've taught students in the past is when you do a stethoscope, don't just lightly hold this here. A lot of times what I'll do is I'll take take somebody's wrist or elbow and squeeze it. So you push down on it. So you can actually hear something. What it'll do is it will help drown out surrounding noise.
What's the other side? I forget.
Huh?
What the smaller side, the smaller valve?
Kids. Pediatric adult.
Pediatric.
So it twists. So you can turn it on and off. But yeah, sometimes when you're bouncing down the road, sometimes having that pushing down and holding someone nice and tight here, sometimes it helps drown out some of that excess noise from the truck and the road. So you won't hear that, and you'll actually hear the blood pressure. Hear the pulse. Actually, you're listening at the pulse is what you're listening at. So you can search for the brachial artery when you're doing your blood pressure. Some blood pressure cuffs do come lining with left and right arms where to line up for the artery. So that's where you line up. This is kind of where you'll feel. You can push in far enough. You can feel your brachial artery in here. It's a little tricky, but you can find it. And once you do find it, that's where you're going to want to put your stethoscope. Is over that position. So we're going to inflate the cuff. You're going to listen and you're going to inflate. Once the gauge reaches 30 millimeter or higher, or you're going to listen. You're going to hear that beat. You're going to hear the pulse in there. Okay, and you're going to keep squeezing so you don't hear that anymore. And you're going to go a little higher than when that noise disappears. About 30 millimeters higher. So blood pressure is measured in millimeters of mercury. Once the sound disappears, you're going to use the little, some cuffs are different. Do you have that other one? So some come with a little turn knob on it that releases the air. Some are like this one where it comes with a little trigger on it. And you can gently release or you can release it all very quickly. So what you're going to do is you're going to be looking at your dial as you slowly release air from the cuff. When you hear the first sound, when you hear the first beat of the heart, that's your systolic blood pressure. So in this case, you're going to watch that needle fall. If it reaches 130 and that's where you hear the blood, that's where you hear that first beat, that's your systolic blood pressure. So that's your top number. You're going to keep listening to these beats, and once it gets to the lowest number, and once the beats stop, once you can't hear any more noise or any more beats, that's your where that mark is, that's your diastolic number. So then you put the two together and you get your blood pressure. Any questions on that one? Okay. So there are other ways. Sometimes blood pressures can be difficult to hear. Sometimes you won't be able to hear them, or you're going to hear them and you're like, I think I heard this to this. So another way to do this is called what we call blood pressure by palpation. And how we do this is we put the blood pressure cuff on someone's arm. You want to demonstrate it? I'm going to just do it on me. Just don't tell them the number, how high my blood pressure probably is right now. So you don't put it on backwards.
It's okay.
So, blood pressure by palpation doesn't require a stethoscope. What you're going to do is find someone's radial pulse before you start pumping up. I can go back towards my wrist a little
Are you
more.
dead?
I don't think so.
Are you sure?
Are you sure? I had it right over
Are you
here earlier.
regardless?
Right there.
Just said, do you need to go back to class?
14 years is a long enough. I've never really had this
Okay.
field.
So you're gonna pump. You're basically gonna pump up the gauge until you can't feel the pulse anymore.
So would that be more accurate in the back of a loud
So
ambulance?
we'll get to that in a second here.
That's your loss.
I think Derek pulled it out of the training stuff.
I don't even need to let it loose.
So once you get it pumped up, the pulse is gone, so you pump it till you can't feel the pulse anymore. And you're gonna slowly let out. When you feel the pulse again, you get your systolic blood pressure. You can't get a diastolic doing this. Go ahead with it.
You want me to tell you out loud?
Go ahead, I don't care.
144.
Actually, that's not bad. that's actually lower than I thought it would be. So this way is not specific. It's about plus or minus 10. That's what I was taught. I don't know if there's actually a specific number, but I was taught palpation can be anywhere from plus or minus 10. So she got 144 for me. So that means my blood pressure could be 134, could be 154, could be anywhere between. What this is just a ballpark range. So it's one of those, it gives you an idea that the blood pressure is somewhere in that 140s range. It's not specific, but the best way is obviously the auscultation, so is listening with a stethoscope. That is the most accurate. Some people argue, say machines are more accurate. I would say the human ear is more accurate when it comes to blood pressures, just because that's just the way I was taught. But obviously machines can be more precise, but machines are machines and machines can easily be thrown off.
Machines are probably more consistent.
They're more consistent, that's definite. But put one of these bouncing down the highway and they can give you all sorts of numbers. But the human ear, once you get to the point of being able to hear the difference between, being able to tell the difference between what you're hearing on a road versus what the pulse actually sounds like, I feel like your ear is going to be more accurate. But I guess I could go back and forth with that. Old school versus new school techniques, I guess, is what you can attribute it to.
If you see something out of alignment too between what you're hearing and what you're seeing,
Right.
one of them's wrong.
Right.
So,
But I'd be more apt to trust my own ears versus the machine in that case.
Yeah.
All right. So as I said earlier, so blood pressure is very difficult to obtain on infants and children younger than 3 years old. Just mainly because to get a really good accurate blood pressure, the patient has to sit still. You really have to hold that arm still. They have to. If you move your arm around, it throws the blood pressure wide off. Does anyone know a 3-year-old that sits still?
No.
So, it's not used.
On our own.
It's not a be-all end-all vital sign with infants and young children. I'm more apt to go off pulse, respirations, and their skin color and condition for kids to judge, make a judgment versus whether they're sick or not sick. All right. So when it comes to the monitor, getting a blood pressure using a cardiac monitor, it's the same thing. The blood pressure cuff has an artery marker. So just like before, you wrap it around, position it that way. The only difference is instead of having to listen, you just reach over to the monitor and you find your NIBP, which just means non-invasive blood pressure, and you just push that, and the machine will take it for you. I don't understand why it says slowly deflate the cuff on that. The thing will automatically deflate when it's done taking. Sometimes if you have to reposition the cuff, if you don't get a good reading, if you have to, you might have to unplug the cuff and just squeeze the air out of it so you can get a good seal on it. All right, temperature. Narrow range of temperature allows chemical reactions and other activities to take place in the body. We're not going to get too far into what those chemical reactions are because that's a semester class on its own. But core temperature reflects level inside the trunk. So, anyone know what the most accurate core temperature is?
Rectal.
Yep. Tympanics are great, but rectals are, when you're dealing with hyperthermic or hypothermic patients, rectals are the gold standard. That is the core, that will be a core temperature. So obviously temperatures fluctuate throughout the day. Adults, we can be, you can vary plus or minus a degree. So you can be 97.6, you can be 99.6, you can be 98.8. Everybody fluctuates. Time of day, activity level, 90 degrees and 90% humidity changes our temperature. So all that needs to be taken into account when you're assessing your temperature. And they also change where. So oral versus tympanic versus rectal. Rectal is the most accurate to the core temperature. Orals and tympanics can be different. We've seen it with the hospital. We take a tympanic temperature and we get 99.8. They go and they do an oral and it's 101.4. You know, so it's those types of temperatures there can be definitely differences in those readings. All right, oxygen saturation, also called SpO2 or oxygen sat. It's sat, not stat. Don't say stat, it's
Not
sat.
2 T's, just one.
Just one T. You'd be surprised at how many people in the medical profession say stat. Garrett. Make fun of him for that. He says it all the time, and I give him crap for it all the time. He says stat. It's actually sat. But anyway, so this measures the ratio of the amount of oxygen present in the blood to the amount that could be carried, expressed as a percentage. So it's supposed to tell you what percentage. So our red blood cells have hemoglobin, where the oxygen attaches to. So what an oxygen saturation meter does, or a pulse oximeter, it tells us what percentage of the red blood cells are saturated with oxygen. So normal is 94 to 100%. That is the normal finding for a pulse ox. Sometimes you'll see them in little devices like this. Sometimes you'll see them in just a single finger probe, which is what I think most ambulances carry. It's just the small little probes. And then they're also on the monitors. So I said 94 to 100% is the normal for a normal person. Anyone with COPD might actually live around 90%. They may even say 88 to 90%. That's normal for them. So always take their history into account when you're looking at their SpO2. Now, the other thing about SpO2, everybody knows CO is dangerous, especially anyone on the fire department. Okay. Pulse oximeters can't tell the difference between CO and oxygen. So if you pull somebody out of a building that's been poisoned with CO, and you put the pulse ox on them and it says 98%, but yet they're out there, they're confused. Well, that's not 98% with oxygen. It just means the hemoglobin's been saturated with 98%. You actually need a special monitoring device to pick up CO. It's called a RAD-57.
You guys don't have one?
No, I don't know many places that have them actually. Cambridge Rescue had one.
Edisburg used to have one. I don't know if they still do.
Yeah, I don't know either. I know Cambridge Rescue used to have one, but it was bought for them by the Smugglers Notch Homeowners Association back in the day. Just like something they bought. They're kind of expensive, but they are specifically designed to tell the saturation of CO2. These things can actually be set up for RAD-57s. Actually, one of them does. I don't know which one it is because it's like randomly, like you put the pulse ox on someone and then randomly sometimes it'll come up with a CO reading. It's kind of odd. But one of our monitors does have it. We don't ever use it, but some of these monitors can be set up for that stuff too. This protocol should govern when to use a pulse oximeter. Pulse oximeters are pretty common, found on just about every ambulance. I think they might be even required by the state of Vermont to have on an ambulance. So you're pretty much always going to use a pulse ox. It's a good baseline to get with patients that are having difficulty breathing, that may have respiratory problems. It's a good baseline to have before you start treatment. So someone with asthma, if they're having an asthma attack and they're 87% on room air, then that's a pertinent finding to be able to tell, like, hey, we give them a non-rebreather and they have oxygen now and now they're 98%. So that's a pertinent finding of they've increased their oxygen saturation. Normal, they say here normal is 96 to 100. By our protocol in Vermont, it's 94% is our cutoff for oxygen versus not oxygen. Again, this stuff can be whatever. Some books even differ on what's normal, so just keep that in mind. Mild hypoxia is considered 91 to 95. Significant or moderate hypoxia is 86 to 90, and severe hypoxia is 85 or less. A lot of things can be affected. The accuracy, shock, hypothermia, as we said, carbon monoxide, excessive movement, try it. You can actually cheat these things a little bit, especially on the pulse reading side of things. See if this thing will work today.
Are you wearing nail polish, Joe?
Oh crap, I forgot to take it off. See if it reads.
%?
99.
That's good. Should also give a pulse. There it is. I'm a little tacky right now. But watch what happens when I start. You can actually get this thing. I've seen people tap their fingers. Some people will have that little tap on their finger, and it'll actually drive the pulse rate to like 150.
Going up
So,
fast.
so you can actually so when you put these on, you definitely want the person to hold their fingers still. Oh yeah, shut up. They also incessantly beep at you. And this thing's like 20 feet long too. Yeah, you grab that one. I'll take care of it in a second. Nail polish, like Courtney said, is another thing that can affect it. Anemia, which is a low blood count, so low red blood cells in the body, can affect it. And then hypovolemia, which is low blood volume. That can also affect so you also have to take into account your readings based on patient's conditions. Alright, glucose meters. Any diabetics in the room? Not to ask pertinent medical history, but just wondering if anyone... No? Okay. So glucometers are a common thing we're going to be using for diabetic patients. Tiny little things like this. They're tiny things. They'll tell you patient's blood sugar. So they come with, typically every one of these things has their own proprietary sticks, I guess. Test strips. Sort of a tiny little thing. Needs a little bit of a drop of blood. Anyone want to volunteer to have their blood sugar taken?
I don't care.
You never let me stab you voluntarily.
Because what he's going to stab me with is a lot smaller.
What, the kitchen knife?
I would stab you.
So the process behind this is pretty simple. You should be wearing gloves when you do this, FYI, people. Probably should grab a pair. Should do it properly if I'm going to do it. Actually, you want to come up front, Greg? So
Sure.
everyone can see easier.
Oh, sorry, I won't lock you.
Do you want me to poke myself?
Oh, sweet.
I think you can if you want. Yeah, that'd be easier. So,
It's
hang on one second. You got smell. There you go. That's alright. I'm going to have him do it himself. So, when you have your thing, so you can kind of put the strip in a little bit. Because these things do time out if you turn them on and you're slow to get the reading. It will actually time itself out. So it's best to just stick it in there, and then right before you do it, just tap it in there and it'll come up with the number. So he cleaned his finger with alcohol. You're going to clean it. You're going to let it dry. Hang on before you do that. Where did I put that? There it is. So you're going to clean the finger with alcohol. Whatever finger you're going to do, go ahead.
I just did.
You poked it.
it. Oh,
Oh, yeah. So clean it up, and then this thing, these are lancets, everyone's a little different. You've got to take this little safety thing off, and then you just push down on that, and it'll poke you. Okay, so the first drop, you always take a piece of gauze, and you wipe it away. And then you milk it back out for some more blood, and it's just something as simple as taking this. All you do is just put it up to the blood, and you'll see it soak up. And you'll start seeing it count down. And his blood sugar is 102, which is normal. Here, go ahead and pull that out. If you want a Band-Aid, there's one right there for you.
I caught up so quick.
Okay.
Thank you, though.
So that's kind of the process behind the glucometer. So the glucometer we're going to be using for diabetics, or anyone that's in an altered mental status. It's going to help you just identify some diabetic emergencies like hypoglycemia or hyperglycemia, or what we call DKA, which we'll get into way down the road. Yep. which we'll get into when we get into endocrine emergencies. But that's a glucose meter. They're pretty simple in operation. Everyone's a little different. Services carry different ones, so just become familiar with your services glucometer. Yeah.
Just a quick question. Right here it says EMTs must have permission for medical direction or local protocol. Can you have patient's permission?
Well, our protocols take care of that. Vermont protocol allows EMTs to do glucometer readings, to obtain a glucose reading. So it's a standing order in diabetics for all levels in this state.
Gotcha.
Only for diabetics or for anyone that
Anyone of altered mental status.
You smell alcohol, that's,
Actually, I think it doesn't. You don't have to have a special circumstance. If you believe a glucose reading needs to be obtained, you can obtain it.
Okay.
So here's just a different type. It's a different type of lancet. Kind of works the same way. These are AccuChecks. That's an AccuCheck. This one's a Sure Prism. So there's different out there, but they all have to use their own sticks, their own little strips.
They expire too.
They do expire, but typically they're like this bottle is almost empty and it doesn't expire until August of 22. There's only like 4 strips left in here, so we go through them pretty quick.
I think temperature can mess them up.
Temperature
storage temperature.
I'm not sure if there's a temperature on them. I do know you're supposed to go through and test these every once in a while. There's control groups.
Mm-hmm.
They send them with like testing solution, and you're supposed to test it to make sure that the glucometer is reading correctly. So when you test control 1 and control 2, you should get readings between the amounts given on the bottle. Some services are more strict on their testing. I know the service I work for in Maine, we check them daily. We had to do daily control tests on them. So we went over how to do it. So normal, again, this is where we're going to differ. So this book says 70 to 100. So when it comes to the MyBrady testing, your normal range is going to be 70 to 100. Vermont, we use 60 to 100. Actually, I think we use 60 to 120 in Vermont. So this is where like vital signs are weird, where we say this is normal, but every book has slightly different norms for certain things, especially glucose. Vermont, our protocols, we treat under 60. Anything over 60, we don't typically treat them for, because that's considered the normal here.
What if it's like in the 200s or 300s?
Get into the hospital. I mean, 2 to 300s, you're looking at hyperglycemia. You could possibly start seeing some signs of diabetic ketoacidosis at that point. Typically, that comes in the 400 to 500 range. And most glucometers won't read above 500. Most like personal glucometers like this. Like I know ours stops at 500, so if it's above 500, it's just going to flash high. So, and if it's below 15, it flashes low.
Sometimes they just flash error.
Sometimes they flash error. Usually that's a user error when it flashes error.
Yep.
I have found either the thing times out or you don't get enough blood in there. So it's typically attributed to a user error when you get that looking, when you get the ERR. All right. Capnography, it's going to measure which I didn't realize is down at the EMT level, so at National Registry. I didn't realize it was.
Years.
So I know, for some reason, I guess I didn't realize it. Yeah. But so this measures the amount of carbon dioxide exhaled. So another word for this, you might see it as you'll see it as end-tidal carbon dioxide, or ETCO2. So when we breathe 21% oxygen. When we exhale, we're exhaling the byproduct of our body, carbon dioxide. So this can tell us a lot about how people's respiratory drive is functioning. Our normal is 35 to 45. That's the normal range that we're looking for. So there's a number of different things. It indirectly indicates how well tissues are using oxygen and performing other physiological functions. So if we're normal, our body's functioning normal. If we're high, we're not functioning properly. If we're low, we're also not functioning properly, usually for different reasons, if they're high versus low. I don't want to get into too much as to the differences between high and low, because we could be here we could be here all night talking about it. It's a very, very dense, very deep subject when it comes to when we talk about acidosis and things like that. And so it's a very, very boring subject and a very long and deep subject. But you're looking for that normal level, 35 to 45. So we have a couple of different ways we measure it. You can, a conscious patient, we have what it's kind of like a nasal cannula. It's kind of hard to see. I don't want to rip one open because it's kind of expensive. But you'll see it's kind of like a nasal cannula with a little sensor on the top here. See, it's kind of like a little. Is there a picture? A good picture in there?
Yeah.
Okay, cool. So yeah, so that's basically what it is. So what it is, it sits in the nose, sits just below the mouth, and it measures the exhaled breath, and it measures the CO2 in it. And different monitors have it differently. Like there's little portable versions on it, so it'll give you a number across the bottom. Where up here where it says end-tidal CO2, it'll give you a number. You're looking for that 35 to 45. So this is for a conscious patient. There's pediatric versions too. There's adult and pediatric. For someone that's unconscious, like a patient that's ventilated, that has a tube in place or is using a bag valve mask, we have a version for that. So this goes between the mask and the BVM, or between the tube and the BVM. And as you breathe for them, when you ventilate them and let go, any exhaled air coming out will register on the monitor. So when you're looking at monitors, sometimes monitors have you'll see two different things. So you guys are looking at the numbers only. So you're just looking at what the number is for end-tidal CO2. So you're looking at the number. There's also what we call waveform capnography. So on the screen here, you have to actually plug it in order to actually see a waveform. But you would actually see a waveform appear as you breathe for a patient. So it might be something you see when you work with an advanced EMT or a paramedic when they put an advanced airway in. You might see the waveform. The waveform tells us other information as to placement and how well they're ventilating. But you guys are looking at just the number. So that's capnography.
What'd you say the normal was for that?
25 to 45. Or 35 to 45. Sorry.
The picture says 21 on this guy, so.
And he's low.
So Joe, like that?
That's your SpO2 waveform.
Okay.
So you're
There's 4 of them on here anyway.
Actually,
Yeah.
the SpO2 waveform is above it.
So if you look on at the picture, this picture right here in the book, so you see that yellow, the third one down, the yellow that has the 21 next to it?
Mm-hmm.
That's the waveform. That's what a capnography waveform looks like. That's actually an irregular waveform, but we're digressing a little bit. Where did oh, there it is. Oh, okay. Apparently it doesn't go over EKGs of application in this chapter, which I'm kind of surprised. Yeah, I'm just surprised it's not covered under monitoring devices, but. So yeah, so any questions on vital signs and obtaining vital signs? No? Cool. What do we got? 7:56.